Good morning, everybody. Can everybody hear me? Yes. Good morning, everybody. Welcome to this session. It will be a literature review of pulmonary procedures and lung cancer. Let's see. Please forgive me. And education. We talked about that. I even forgot that. Not enough caffeine yet. So let's get started. I hope you're having a good chest session so far. I did a literature review for the past year of most of the pulmonary procedures that have been published, and I picked out a few that resonated more this year, and you'll see a lot of sessions about them. For conflicts of interest, I have no current or potential conflicts of interest to this presentation. There. Our objectives today will probably go over bronchoscopic cryobiopsy in interstitial lung disease, the new trial that came out for the bronchoscopic lung volume reduction in emphysema, the interventional treatment of pulmonary embolism, and lastly, an elegant study that was done with regards to using ultrasound in the evaluation of dyspnea in the emergency department. Starting with the cryobiopsy. So usually for interstitial lung disease, when we see that CAT scan with interstitial changes, the gold standard so far to obtain a diagnosis is surgical lung biopsy. And we struggle when we do bronchoscopy for these patients that the samples are quite inadequate. Lately, the cryobiopsy, initially cryotherapy was used as a therapeutic modality, but more and more it has been used as a modality to obtain architecture intact samples. And so in the cryobiopsy, and I tried to obtain a video, I'm afraid the technology didn't work quite right. So in the cryobiopsy, there's a probe that is advanced through the flexible bronchoscopy, and it is placed near the chest wall, and the probe is cooled for a few seconds. Such seconds also is a modality to, I guess, impact the quality of the biopsy itself. And after freezing, the lung tissue sticks to the probe, and the scope and the probe then are both removed. Next to the flexible bronchoscope, there's a balloon that is advanced past the cryoprobe, and it is then inflated to control the balloon the bleeding downstream. Cryobiopsy is known to obtain larger samples with less avulsion artifact compared to the forceps transbronchial biopsy. In this study at the Mayo, transbronchial biopsies and cryobiopsies both were obtained sequentially in one hemithorax of 56 patients. So they did 1 to 10 passes of about 0.1 to 0.8 centimeters each. And then the cryobiopsy was about 4 to 5 seconds freeze time, up to 4 samples. And the sizes were 0.4 up to 2.6 centimeters. So already the size was much more significant. They were reviewed by independent blinded pulmonary pathologists. And the question to them was if the diagnosis was defined by the transbronchial biopsy, the cryobiopsy, both, or non-diagnostic. And in this study, 45 out of 56 patients, or 80% of them, had a definitive diagnosis. 46%, both technique provided the same diagnosis, and 27% of diagnosis made by only one technique. In those, of the 15, the majority, the diagnosis was made by the cryobiopsy. And as you see, the diagnoses were made mostly of hypersensitivity pneumonitis, organizing pneumonia, sarcoidosis, and drug reaction. Now, immediately you start thinking, well, where is UIP? And there was a question following that, and an answer by the authors, where they looked at mostly those UIPs. They were probably radiologically typical, and they were sent to surgical biopsy. And they looked at the referrals during that time period, and there were about 43% of all the interstitial lung disease patients that presented were sent to surgical biopsy. So that may have created a skew away from UIP. Be that as it may, those are the majority of where the diagnosis was made by one technique only. The cryobiopsy was clearly taking the lead. Now, as far as safety in this study, there was massive hemoptysis in one patient, more bleeding in general, mild to moderate, and a pneumothorax was seen in 20% of those patients, higher in the transbronchial biopsy alone, and may be attributed to cryobiopsy or the combination of both. This has been the conclusion of the authors, although pneumothorax has been seen in subsequent studies with cryobiopsy. The limitation of this study was retrospective, single institution, only 56 patients, and the techniques were not compared to the surgical lung biopsy, and also, as you saw, the biopsy numbers differed by patients. Now, in 2014, there was a study from Barcelona which published the first and only randomized controlled study comparing the diagnostic yield of transbronchial versus cryobiopsy in ILD. And there was, again, similarly higher diagnostic yield in cryobiopsy, more grade 2 bleeding, moderate bleeding, and it occurred in the cryo group more than the conventional forceps group. Recently, there was another paper that came out in the Journal of Bronchology, Interventional Pulmonology, where they used the combination of both cryobiopsy as well as the radial ultrasound in an attempt to identify in the site of the cryobiopsy, was there by Doppler any blood vessel feeding that area to try to decrease the bleeding. The complications, this is a study from Portugal, and they looked mostly at, in a prospective evaluation of all patients referred to that ILD center, 90 patients were included, 58%, 59% were male, as could be expected. 22 patients sustained a pneumothorax, 81% of which needed a chest tube for about a day, and as could be expected, the presence of visceral pleura was highly predictive of pneumothorax. Again, same thing, grade 2 and grade 3 bleeding in 13 patients with an increased BMI associated with the bleeding, with 16% additional odds for each BMI unit. So I thought this was an elegant study to include for the complications. Lastly, Oxford published in their quarterly Journal of Medicine this systematic review looking at the cost analysis and whether there was any savings with regards to using cryobiopsy. Now, I am not so sure if they included in the cost analysis the cost of treating the pneumothorax. Be that as it may, the conclusion was they had at least 200 pounds more or less of cost savings per patient in the first year, and even later on there was more. I think this needs to be looked at more to see if that cost analysis includes the treatment for the pneumothorax and the subsequent stay in the hospital, at least for a day or two. So, switching gears, I wanted to bring up the IMPACT study, which we had been waiting for. As we all know, when it comes to end-stage lung disease and emphysema, there are many, not that many modalities, and we had looked at lung volume reduction surgically, but how many patients first qualify and second can undergo the surgery and emerge the other way safe. So usually the lung volume reduction it looks mostly at upper lobe rather than a homogeneous emphysema. This was different in this study where they looked at severe homogeneous emphysema patients. Endobronchial valves have been offered as an alternative where unidirectional endobronchial valves are placed with the aim to occlude and collapse hyperinflated lungs and allowing the trapped air to escape from the target lobe. Now, some post hoc analysis of such trials did help identify who are most likely to benefit, and I'm going to go over these. So what are the benefits of lung volume reduction? Reduction of dead space, increasing the elastic recoil, and improving the dynamic compliance. You restore some of the diaphragm excursion and efficiency, and then you improve the mechanics of chest wall versus diaphragm. Starting with the NET trial, there was a total of 1,200 patients with severe emphysema that underwent pulmonary rehab and then randomly assigned to lung volume reduction surgery consistent with bilateral wedge resections or just continued medical outcome. And the outcomes primary were mortality and exercise capacity at 2 years, and secondary were 6-minute walks, PFTs, quality of life, dyspnea score, et cetera. The homogeneous emphysema was excluded, and FEV1 and or DLCO that's less than 20%. And mostly the upper lobe predominance with low baseline exercise capacity showed an improvement. So this is what led to using lung volume reduction in that subgroup of patients. No difference in mortality. Surgical complications had 90% of these patients had air leaks of 1 week duration. And this is the kind of valve that I'm talking about. So when you put them in the airway, it allows, this is a one-way valve. This is a sort of a metal kind of a valve that allows the air to come out but not go in. And so it causes an iatrogenic atelectasis. Followed by the vent trial, and I'm going to skip over these, but basically it showed effectiveness in the FEV1 and 6-minute walk test change at 6 months, and the safety showed a difference in the rate of 6 major complications, death, empyema, massive hemoptysis, pneumonia, and pneumothorax. And the trial results were that FEV1 and 6-minute walk test did have somewhat of an improvement, modest improvement in the scale scores, but not significant at 12 months. And at 90 days, there was an increase in acute exacerbations, some hemoptysis, and pneumonia in the target lobe. And the FDA reviewed the trial and showed that recommended against the approval due to mild benefits. So there was a study about why did this happen, and the concept of collateral ventilation showed that even if you had, for example, a target lobe here or here, and you wanted to place the valve and look at this lobe and collapse it, some patients may have fissures that are interrupted and have some interlobar collateral ventilation due to anatomic collateral ventilation, which becomes even more pronounced in emphysema patient due to the distension of the lung. Long-term survival, successful valve treatment was mostly when the target lung volume is observed on the CT. So you actually have to do a CAT scan afterwards and find that the lobe is collapsed before you see the benefit. This is the IMPACT trial, and this one is the first prospective multi-center randomized controlled trial evaluating the safety and the efficacy in homogeneous emphysema and consistent in homogeneous emphysema, and it was done in Austria, Germany, and the Netherlands. 8 sites total. More than 40 years of age, ex-smoker, severe emphysema, very obstructed, despite optimal medical management. The TLC was more than 100, it was up to 250, residual volume of at least 200, and other criteria, 15%, there had to be, the definition of homogeneous emphysema, there had to be a less than 15% difference in emphysema destruction score between the target and ipsilateral lobes based on density scores of the target lobe. Which lobe are we going to collapse? And 20% difference in perfusion between the right and the left lung using perfusion scintigraphy, and those 2 criteria had to be met. The lobe with the highest emphysematous destruction, the lowest perfusion score in the absence of collateral ventilation, was chosen as the target lobe. And I'm going to try to move quickly. They had 183 people consented. 90% were excluded. 93 were randomized, 43 to the endobronchial valve and the standard of care group with 3 months follow-up. These are the baseline demographics, and they were pretty well matched in almost all of the scores. And these are the patient outcomes. This is for the intention to treat, and this is per protocol. And there was a difference of about, this is the percent of FEV1 change from baseline up to 3 months. And there was, between standard of care and endobronchial valve, about a 17% improvement. Median number of valve placed were 4, 42% in the left lower, 28 in left upper, 21 in the right lower, and 9% in the right upper. And the median hospitalization stay was 6 days. And of these EBV-treated patients, 97% experienced a reduction in the lobar volume in the target lobe. 88% achieved the target lobe loss, volume loss of about 350 milliliters. The primary endpoint, there was an improvement from baseline of 13% of FEV1 plus or minus 28% in the EBV group, whereas in the standard of care, it declined by 3.2%. So these are the response. This is just a minimally clinically important difference in the key outcome measures with regards to the FEV1, which was approximately 34% of them improved their FEV1, minimally clinically important difference by 15%. Residual volume, SGRQ, 6-minute walk test by more than 26 meters. The limitation of the study had no consensus. There is no general consensus of what homogeneous emphysema is. They chose their own definition, but there is a call for future studies to confirm if the usefulness of the target lobe selection algorithm implemented in the present trial based on the CAT scan itself and the difference of 15% as we showed. There's no sham procedure that would have that was done. Standardized pulmonary rehab was not performed as part of the pre- and post-procedural patient care. It was just on the standard of care patients. Outcomes are short-term, 3 months only, and the participants had severe gas trapping with a mean of residual volume of 275% predicted. So if you start sending patients that are less, that have less gas trapping, relaxing those criteria in the community may have less improvements as we saw in this study. The pneumothoraces did occur at 25% within a few days and responded to chest tube drainage. And they concluded that even in homogeneous emphysema without collateral ventilation, the endobronchial valve therapy is useful. So moving on, I wanted to touch briefly on the interventional treatment of pulmonary embolism. We know it's the third most common cause of cardiovascular death in the US. The treatment options are anticoagulation, thrombolysis, or interventional approach. The problem is mostly in the submassive. You have an acute PE without hypotension, but there is some RV dysfunction or troponin level that's elevated. And the ultrasound-directed thrombolysis is the technique talked about in this particular study. And actually, what is ultrasound directed? There is an infusion catheter and an ultrasonic core. The infusion catheter is what allows the TPA to be infused intravenously, but directed at the area where the PE is. And the ultrasonic core sends ultrasonic waves, and those are allowing both accelerated delivery of the thrombolytic, which is called acoustic streaming, and disaggregation and conformational change of the actual clot, which is called thrombus conditioning. That is thought to enhance the delivery of TPA. The Seattle 2 study led to the FDA approval of the device in lower dose, and that had shown at that time 0% intracranial hemorrhage with general bleed of 10%. As you all know, 3% intracranial bleed was shown in systemic TPA when we send those patients up for thrombolysis. So in this study, the optimized PE, they took 4 dose arms for patients with 2 catheters. They placed 2 catheters on either side of the patient, and they used 8 milligram for 4 hours, 8 milligram for 4 hours, 12 milligram for 6 hours, and 24 milligrams for 12 hours. Major bleeding in higher dose, mostly seen in the higher dose, but no major bleeding in these doses, showing that less time and less drug can achieve the same clinically important outcome. And in that outcome was actually seen by the RV-LV ratio, which here is more than 1. This is about 2.5 times. This is about 0.9 to 1. So this is before, this is 48 hours after. And so that was the primary outcome that was met in the Seattle 2, and it was met in the optalized PE as well. And they raised the question of, in their hospital, that they have the concept of pulmonary embolism response team, which involves ER physicians, critical care, pulmonary cardiology, interventional radiology, and cardiovascular surgery. And they were able to respond to pulmonary embolism immediately, either in the ER or inpatient, with ultrasound catheter-directed thrombolysis, showing that you can meet both quality of life subjective measures as well as outcomes. And we probably need to look at further mortality studies and replication of these before it becomes mainstream. In lack of time and respect for my other presenters, I'm going to skip the last one. It's going to be on the taped or recorded lecture later on if you wanted to have access to it. My next presenter is Dr. Choi from Cleveland Clinic, and he's going to talk to us about lung cancer. Thank you.